Hey guys, welcome back. This is Dr. Marva, and today we shall be discussing some multiple choice questions. The objective of today's session is mainly to sharpen your reflexes, and you very well have some important exams coming up in the month of June 2021. So without wasting any time, let's get started for today. A relatively easy one, I would say. Please keep on commenting in the chat box or in the live chat so that I can moderate and have a look at what your first thought process is. This question talks about a 20-year-old male transported to the emergency room after a motor vehicle accident. He is having chest pain. So the moment you read a question with respect to motor vehicle accident, two things should always come to your mind: cardiac tamponade and tension pneumothorax. The patient is hypotensive and he's mentioned about pulsus paradoxus and the heart sounds are distant. So very well you can pick up that the question is giving you information with respect to Beck's triad, and that goes in favor of cardiac tamponade. He says the examination of the neck veins fails to reveal a Kussmaul sign. That's an important indicator of cardiac tamponade per se, because you always have a pulsatile neck veins, right? In every time there's a cardiac condition, even in congestive heart failure, though JVP is elevated, it is still pulsatile. But non-pulsatile JVP is a feature of cardiac tamponade. The ECG of the patient at the moment is unremarkable, though sometimes electrical alterance can be picked up. And what he has categorically asked here is that a right heart catheterization of the patient was done, and he says which of the following values are consistent with the patient's diagnosis. So it is a two-step question. Step one would be that you will have to obviously read the information and come to the diagnosis of this case, which is cardiac tamponade. And point number two would be that you will have to apply a bit of logic so that you can apply these pressures. Now the basic concept behind this particular topic is, before I draw a line diagram, I want to highlight that in pulsus paradoxus, which is a characteristic feature of cardiac tamponade, what basically happens is that the pressure in the chambers of the heart tends to equilibrate. What I mean by equilibration is, and now I'll just hand draw a quick diagram before you. If this is the representation of the septum, the right and the left ventricle, these are the two atria. The problem in this chap is that there could be substantial amount of blood which could be compressing on the heart from outside. So we are talking about a cardiac tamponade where the inflow into the heart is limited. Why am I saying the inflow into the heart is limited? You see, the pressure which is exerted from outside will limit both the venous return into the atria, and not only the venous return will be hampered, even the flow of blood from the atria to the ventricles will be hampered. The way I have shown the diagram, I want to highlight that in color blue. This is the vector, this is the pressure which is coming on the heart from outside. So as a result of this, the filling of blood in the heart tends to reduce. This explains why the pulse pressure is decreasing to the level that it might disappear during the phase of inspiration. Now let's simplify the facts. In pulsus paradoxus, there is no flow of blood from one chamber to another. Like you are very well aware, right from your biology classes, that blood will flow from the pulmonary artery towards the left atria, from the left atria into the left ventricle, so on. So there are two terms that I want to highlight. One is pulmonary capillary wedge pressure, PCWP. Normal pulmonary capillary wedge pressure is about 8 to 12 millimeters of mercury. What I want to highlight is pulmonary capillary wedge pressure is the force with which the blood will enter into the left atria, entry to the left atrium. Now, pulmonary artery pressure will be dependent on obviously the exit from the right ventricle. In you and me, the pulmonary artery pressure, listen to the words very carefully, the pulmonary artery pressure in a normal individual should be such that it should ensure forward flow, right? The blood from the right side of the heart should go into the left side, so there has to be a forward flow. But if the pressure between the two will equilibrate, in cardiac tamponade, the pressure from the outside will cause equilibration of pressure in all the chambers of the heart. And if the pulmonary artery and PCWP pressure, just एक सेकंड के लिए सोचो, अगर pulmonary artery और pulmonary artery का pressure right side of the heart के साथ linked होता है और PCWP is linked to the left side of the heart. If these two pressures will become equal, then there will be no flow of blood. And if there's no flow of blood, the blood pressure of this guy will collapse. Now, when you look at the values, all you need to do in this question is look at the option in which the pulmonary capillary wedge pressure value and the pulmonary artery pressure is equal. And when you glance through the options here, आप यहाँ notice करोगे कि जो pulmonary capillary wedge pressure है, it's slightly elevated, it's given to be 16, but you will notice that in option number B, all the pressure values are equal. So all I want to highlight with respect to cardiac tamponade is that there is, because of extrinsic pressure on the heart from outside, there is equilibration of pressure between all the chambers of the heart. So there is impeded venous return, there is an impeded forward flow, and as a result of this, the blood pressure of this patient will crash. And unless and until you do a pericardiocentesis, which we have talked about in one of our previous sessions also, if you don't do that, this guy with obstructive shock will expire. The correct answer to this particular question, though I had variable responses in the chat box, would be given as option number beta. I repeat the fact once again, I'll keep it short and simple. Cardiac tamponade may venous return into the heart, in and out, both is hampered. This is because of equilibration of pressures between all the chambers of the heart. As a result of it, you will have to select option number B, because if you look at the pressure in the pulmonary artery, diastolic is 16 and PCWP is also 16. If these two pressures are equal, there is no forward flow of blood. And I want to remind you guys once again that PCWP is basically the pressure with which the blood fills in the left side of the heart. And pulmonary artery pressure is obviously, very straightforward. You know that from your biology classes. I don't need to explain that. But I think that I've had variable responses for question number 1. So yeah, keep on, commenting, and I'll keep on rather telling you how to adjust your answers. And I also want you to sharpen your thought process, because you get something under, I would say, 60 to 75 seconds maximum to solve a question. And irrespective of whichever exam it is, I just want to make one thing clear, that if you practice questions daily, now's the time for it. In fact, then your reflexes will become sharpened and you will be able to solve these questions in, I would say, the limited time frame. Coming to question number 2 for today, this talks about a 30-year-old man who was assaulted with the goons and was hit on the head by a lathi. He was brought into the ER unconscious. GCS of the patient is definitely in the range of coma. It's only 5. You know very well less than 8 is coma. And he says, which of the following is correct about the diagnosis of brainstem death in this patient? Now, before we read the options, I want you to be very clear about the fact that when you read the word brain death, it basically means brainstem death only. Cortex may still be alive, spinal cord may still be alive, so spinal reflexes might still be elicited. Let's read option number A. It says bilaterally constricted pupils with poor reaction to light must always be present. Well, for diagnosis of brainstem death, the technical word is fixed pupils. It is fixed, non-reactive pupils. So I'm ruling out option number A. Is asking you what is the correct statement. Why option number A is the wrong one is because you should be having is no reaction to light and the pupils should be fixed. That implies the fact that the light reflex is gone, midbrain is smashed. Option B says absence of corneal reflex indicates loss of midbrain function. Now please remember the fact that corneal reflex root value is 5 and 7, and when it comes to the 7th cranial nerve, the location of the 7th cranial nerve is not the midbrain. The midbrain will be giving rise to cranial nerve number 3, 4 and 5, whereas cranial nerve number 7 is going to be related to the pons. So why option number B am I ruling out is because of the fact that corneal reflex, if it is absent, it indicates that it's the pons of the patient which has been damaged. Let's read C. Motor reflexes, like you're doing a sternal rub in a patient, you very well know you can either use your thumb and press on the supraorbital notch, or you can do a sternal rub, and sternal rub will contribute to obviously pain and discomfort in the patient, so patient will be having a motor response. Now I want you to understand that if somebody is brain dead and if you do a sternal rub, there might be movement of the arm of the patient. A non-medical family member will look at this arm movement and say, sir, what are you saying? You are saying my family member is brain dead. I saw a movement. Please, you guys are technical people, so it's easier for me to explain to you guys, but it's very difficult to explain to especially Indian people and especially to non-medical people that brain death means brain stem death. Spinal reflexes could still be present. You are giving a noxious stimulus, so therefore there might be a movement of the arm. In fact, I want to highlight option number C is a wrong statement. And why I'm saying wrong statement, I can give one more example. Like you declared somebody as brain dead person. You told the family member, okay, go and meet this person for one last time before the organ transplantation team takes over. And this guy goes and touches the hand of his father, and his father grabbed his finger. He says, sir, you were telling me that my father is brain dead and he's grabbing my finger. See, that's a grasp reflex, no? Because cortex is still alive, the frontal lobe damage can manifest a grasp reflex or a primitive reflex. The point is that cortex might still be having some amount of blood supply, but the brainstem where the vital centers are present is totally smashed. Similarly, spinal reflexes can be elicited. You might see a flickering movement of the fingers or toes of a patient. That does not mean that he is not brain dead. I repeat that fact once again. If you see a physical movement like flickering of toes or a grasp reflex, that does not mean person is not brain dead, because spinal reflexes could still be present. If you read the lining of option number C, which a couple of you commented, motor response to sternal rules out the diagnosis per se. The wrong statement here, it is written, it is rules out the diagnosis of brainstem death, whereas that is not the case. Spinal reflexes could very much be present. So the correct answer for question number 2, which I found more people answering correctly as compared to question number 1, and that's what happens in the exam. Once you get into the exam, your mind gets into the groove and you are able to then jump from cardiovascular to central nervous system, from central nervous system to rheumatology. I mean, that's the capability I want you to have, because when we are doing questions in the app, like you might be doing only GI questions or you might be doing only rheumat questions, but you need to have that capability to jump from a topic to another. Not only jump from one topic to another in a particular subject, but ability to jump from one subject to another one. That's what ultimately matters. The correct answer to this question is option number D. By exclusion, let's read it out anyway. Cuff reflex to suction cannula placed down to the carina will exclude the diagnosis of brainstem death. See, the basic point is that if cuff reflex is present, then you cannot call a person as brainstem dead. If cuff reflex is absent, that is when a person is brain dead. And let's just quickly revise the features also of brain death. So I'm just going to show you a slide. The first and the foremost would be that you need to demonstrate presentation of irreversible coma in the patient. You see, you have to rule out obviously opioid abuse, that's a reversible cause. Diabetic ketoacidosis, non-ketotic hyperosmolar coma, hypernatremia, hyponatremia, they are all reversible causes. So he says the fact that you must demonstrate irreversible brain damage. Obviously, nowadays we can simplify things by doing a MRA, which will show no flow of blood to the brainstem. But at the same time, you must have two doctors who must demonstrate this. Pupils should not be reactive to light. Corneal reflexes should be absent. If pupils are not reacting to light, it means midbrain is smashed. If corneal reflexes are absent, it means that the pons of the patient is not working. On the other hand, when there is no gag reflex, when there is no cuff reflex in the patient, it basically means that the pons of the patient is also hampered. And obviously caloric stimulation test should be negative. And when you do or when you disconnect the patient from ventilator, there should be no breathing movement, not even a gasp, because the respiratory center, the pre-Butzinger complex has been affected. So there would be no spontaneous respiratory drive in the patient. Please go through the topic of brain death per se in neurology that I've discussed in the app, in case you could not get this question right. But I personally feel that this was relatively an easy one, and it is only those terminologies like rules out the diagnosis, excludes the diagnosis, includes the diagnosis. Like half the time I would say that in an Indian exam they're testing your English, so you just need to sharpen your reflexes for the same. Answer to question number 2 is delta. Let's move on to the third one for today. We are having a patient of COVID-19 pneumonia on day 10 and he's having desaturation. I think you have all listened to the COVID lecture. You very well know most desaturations in COVID-19 occur between day 8 to day 10. And I mean, that's when the happy hypoxia gets converted into a hypoxia when a person is saying himself, I am having shortness of breath. I mean, if you talk to somebody with COVID-19 pneumonia on 5th or 7th day, he is pretty happy, you know, Baba Ramdev ki coronel kha raha hai. बट 8वें दिन उसको ऑक्सीजन की रिक्वायरमेंट आ जाती है. दैट इज व्हाट यू हैव सीन, दैट इज व्हाट हैपेंस. सो यू स्टार्टेड द पेशेंट ऑन अ नॉन रीब्रीथिंग मास्क विद ऑक्सीजन फ्लो एट 15 लीटर्स पर मिनट एंड द सैचुरेशन इज स्टिल 85%. अगर ये सैचुरेशन नॉर्मलाइज हो गई होती तो मैं बोलता ठीक है यार, यू नो लंग्स में डैमेज था एंड मैंने ऑक्सीजन सप्लीमेंटेशन किया, ऑक्सीजन सैचुरेशन हैज टर्न्ड आउट टू बी 95%, कूल, ग्रेजुअली द पर्सन विल रिकवर, बट ऑक्सीजन saturation is still low. So there are two possibilities. One is that the pneumonia is very extensive. Second could be that there could be pulmonary embolism occurring in the person. How do I know it is pulmonary embolism? See, CRP is 100, that's elevated. D dimer is 10x of normal. So that means that there is microemboli which are being formed. As I've told you that per se, when it comes to COVID-19, it's not only about being a pneumonia, it's also a hyperinflammatory response, which can contribute to multiple emboli that can go anywhere. You could be having this emboli going into coronary circulation. He can develop a MI. I lost a couple of patients because of that. In this patient, the microemboli are going into the branches of the pulmonary artery, and he has himself told you that the patient is having a submassive pulmonary embolism. He says select multiple options. I mean, this question is obviously, I would say, more of any set pattern. He mentions the fact that, but even if you're sitting for an FMG exam, doesn't matter, because objective for you is that you should be able to differentiate between massive versus a submassive pulmonary embolism. Option A says dilated right ventricle on echocardiography. You see, if there's blockages in the pulmonary artery and its branches, due to this physical blockages, the right ventricle will have to work harder and it might actually fail and dilate. You very well know that in pulmonary embolism, you get right ventricular failure. And when I say the word failure, the poor heart will dilate. So option A definitely looks like a okay one. Option B says systolic blood pressure less than 80 millimeter of mercury. Please remember the fact that systolic blood pressure less than 90 is a feature of massive pulmonary embolism, where a person could be having a big embolus in the main pulmonary artery trunk, or it could be a saddle embolus. Hypotension is not a feature of submassive. Hypotension is a feature of massive pulmonary embolism. तो ऑप्शन नंबर बी तो बनता नहीं है. सी में लिखा है elevated troponin. देखो, there can be two reasons why troponin could be elevated in this particular case. One, I said the emboli which are formed in COVID-19 could go into coronary circulation, so it could contribute to a MI. The second possibility is that because right ventricle is getting grossly dilated, and I would say that the requirement of the heart is much more. The requirement of the heart is much more because it has to pump against a resistance. So there might be a mismatch between demand and supply, and every time there's a mismatch between demand and supply, there could be actually micro infarctions occurring in the heart that can raise cardiac biomarkers. Cardiac biomarkers can be elevated even in pulmonary embolism. They can cause a misdiagnosis of this person as inferior MI, because a biomarker is elevated, you will think it is inferior MI. But the point I want you to understand is that cardiac biomarkers in COVID-19 can be increased due to two reasons. Either the microemboli are going down into the coronary circulation, or even pulmonary embolism itself, because the demand of the heart has increased, or there's a resistance to the outflow from the heart. So there could be a possibility of elevated biomarker. BNP level of less than 10 picogram per ml. Now, I do not know the actual value. Let me say at an undergraduate level, at an MBBS level, I may not remember what is the actual lab values of BNP, but I just at my subconscious level know the fact that every time there's a heart failure always causes BNP levels to spike. But in this case, the values are given to be lesser, so it becomes a little unlikely. And anyway, in the selection options per se, he has made things easier for you by making you select only two. I mean, it's a combination of A and B, A and C, like that. So you can see that A and C are the correct options, which will make the correct answer as point number 3. And I think it's well done by most of you who have selected option number 3 here. Please remember the fact that when it comes to even pulmonary embolism, there's a possibility of a false positive. False positive, I am saying, because the problem is actually with respect to the pulmonary circulation. It's not the coronary circulation, though I gave you another reason for COVID-19 also contributing to it. But per se, specifically in pulmonary embolism, also biomarkers can be elevated, and that's one of the common reasons that pulmonary embolism can be missed, because if biomarkers are elevated, you start thinking in terms of MI, and you might be giving treatment in form of MI also. There are two messages from this particular question. One, I mean, in case you got it wrong, you just need to get back to your notes and have a quick look at the table where I've compared massive versus submassive pulmonary embolism. That's message number 1. Message number 2, I want you to understand is in COVID-19 pneumonia, if a person's oxygen saturation is not improving, what could be the reasons? One of the important reasons if the oxygen saturation is not improving is that if you are gonna give high flow oxygen, and you would have noticed in COVID-19 pneumonia this has happened, oxygen saturation not improving, pneumothorax could have occurred. You might have to put in a chest tube. Another reason could be he's having pulmonary embolism. Another cause could be that he could be having myocardial infarction. I repeat the fact once again, if there is no improvement of oxygen saturation, there could be lung collapse also. I've seen cases where there was a hemoptysis and lung collapse, but I'll reserve the lung collapse component to a different discussion in subsequent days. No improvement of oxygen saturation in COVID-19 pneumonia. in spite of oxygen supplementation being given. And I'm not saying that I'm giving simply oxygen with nasal cannula or with a Hudson mask. I'm using if I'm using a aggressive modality, if I'm using an NIV or if I'm using a non-rebreather mask, then I expect that the oxygen saturation of the patient should dramatically improve, or at least it should become respectable, usually in excess of 90s. The correct answer to question number 3 is option number 3. Job well done by most of you. Let's move on to the next one for today. This topic, I know everybody would be like, yo man, I'm gonna get this right. What is correct about inflammatory bowel disease? Yes, guys, I give you 30 seconds. Quick read. Hey, this time not giving you 1 minute. I'm giving you 30 seconds. Just solve this question, and a relatively easy one. I'm gonna read out the options before you. CARD15 gene on chromosome 15 is responsible for Crohn's disease. Now, when it comes to genes, honestly speaking, when I look at myself when I was at your age, this was a nightmare, remembering genes on which chromosome. So what I did was, in the end, your timer is still running, guys. Keep on commenting in the chat box whatever is the correct answer while you are listening to me. When I was at your age, I had a nightmare with respect to genes and chromosomes. So one fine day, I just sat down and I started writing chromosome 1, these many genetic defects and diseases I know. Chromosome number 2, these many diseases I know. Like I wrote it from chromosome 1 to chromosome 22, and well, I made it easier for you in the like I'll post this in my Telegram group, the PDF of this file. So in that PDF, I will be including the genetics component as well with respect to genes, right? I mean, because questions with respect to genes and chromosomes are very simple and straightforward. It requires a bit of cramming, so you need to see that file again and again. So I'll attach that file in the PDF of this one also, and put it in my Telegram group, that is Top Educators, which you can join. And meanwhile, I'll say that option number A is maybe right, maybe wrong. So I'll say, okay, let's read B. ASCA, anti-Saccharomyces cerevisiae antibody is found in 70% patients of ulcerative colitis. You very well know this is a wrong statement, because ASCA is what you read with respect to Crohn's disease. So I'm very confident about ruling out option number B. Option C says antibiotic usage in the first year of life reduces the risk of childhood ulcerative colitis. C, inflammatory bowel disease is due to imbalance between the good bacteria and the bad bacteria. For that harmonious balance, antibiotics should not be given. I mean, if you are giving antibiotics, like is very common in our country, children suffer from diarrhea in the first year of life and we start giving antibiotics. है ना? आपने pediatrics में Norflox TZ कितने बच्चों को लिखा हुआ? सिर्फ Norflox TZ. लेकिन जब आप एंटीबायोटिक देते हो बचपन में, तो फिर जो बैक्टीरिया, गुड और बैड बैक्टीरिया का बैलेंस होता है, वो डिस्टर्ब हो जाता है. और एंटीबायोटिक इन फर्स्ट ईयर ऑफ लाइफ हैज बीन डॉक्यूमेंटेड टू कॉज, आई मीन दैट्स एन एसोसिएटेड फैक्टर, कि अगर किसी को बचपन में रिपीटेड एंटीबायोटिक के कोर्सेज मिले हैं तो उसको बाद में जाके आईबीडी होने के चांसेस ज्यादा होते हैं. In option number C, the wrong statement is, it is written it reduces the risk of childhood ulcerative colitis, जबकि ऐसा नहीं होता. If a child, if a child has received antibiotics in, let me say, first year of life, infancy, तो उसमें childhood ulcerative colitis का incidence relatively increase हो जाता है, तो option number C बाहर हो जाता है. डी में लिखा है स्टार्टिंग ऑफ स्मोकिंग विल ट्रिगर अल्सरेटिव कोलाइटिस. आप सभी जानते हो, आई मीन एक बेसिक सा स्टेटमेंट है, अल्सरेटिव कोलाइटिस एंड स्मोकिंग इन अ सेंस कि स्मोकिंग improves the prognosis in ulcerative colitis. I mean, all through our medical college, हमेशा हम पढ़ते हैं ना, smoking causes a problem, smoking causes this disease, but which disease improves with smoking? Ulcerative colitis. Looks funny, but is true. Now let's read D again. Starting of smoking will trigger ulcerative colitis relapse. No, it will suppress it. Rather, जब वो सिगरेट छोड़ देगा, तब वो बोलेगा कि सर मेरे को रिलैप्स फिर से हो रहा है. इनफैक्ट बहुत सारे इन्फ्लेमेटरी बowel डिजीज के पेशेंट ऐसे होते हैं जो बोलते हैं सर जब से मैंने सिगरेट छोड़ा तब से मुझे आईबीडी का प्रॉब्लम स्टार्ट हो गया. फनी लग रहा है, बट ऐसा ही है. पेशेंट बोलता है सर जब से सिगरेट छोड़ी है ना, तब से स्टूल में ब्लड आता है. वो क्यों आता है? क्योंकि आईबीडी को पहले प्रोटेक्शन मिल रहा था स्मोकिंग से, अभी नहीं मिल रहा अल्सरेटिव कोलाइटिस का कंपोनेंट को. ऑप्शन नंबर डी में गलत क्या लिखा हुआ है? इट विल ट्रिगर. इट विल नॉट ट्रिगर, रादर इट विल सप्रेस. सो आई हैव डेलिबरेटली इन दिस क्वेश्चन केप्ट 5 ऑप्शंस, क्योंकि मैं थोड़ा आपको परेशान करना चाहता था. लेकिन मैं इतना जानता हूं कि स्मार्ट गाइज लाइक यू बी सी डी तो रूल आउट कर लोगे. अब बचे दो. कार्ड 15 जीन ऑन क्रोमोसोम, when card 15 gene on chromosome 15 or acute flare up of IBD is I mean acute flare up of IBD is caused by use of NSAIDs. इन दोनों में से एक select करना है, which is gonna be the correct statement. So let me, I mean, obviously I had to, create some trouble for you guys. So usually in the chat box A versus D का ही competition चलता है. And before I mark the right answer, मैं यहाँ पे highlight करना चाहता हूँ कि देखो नॉन स्टेरॉइडल एंटी इन्फ्लेमेटरी ड्रग्स के यूज से पेप्टिक अल्सर डिजीज तो होता ही है, बट इवन आईबीडी का इंसिडेंस और फ्लेयर अप्स का इंसिडेंस ज्यादा होता है. क्यों? बिकॉज यू एज डॉक्टर शुड बी नोइंग दैट प्रोस्टाग्लैंडिन्स, लिसन टू माय वर्ड्स वेरी केयरफुली, प्रोस्टाग्लैंडिन्स हैव अ प्रोटेक्टिव रोल not only with respect to stomach mucosa. Listen to my words very carefully, guys. Prostaglandins have a protective role not only with respect to even the stomach mucosa, but they have a protective role even with respect to the colonic mucosa. तो अगर आप प्रोस्टाग्लैंडिन्स का लेवल कम कर दोगे, तो जैसे ही प्रोस्टाग्लैंडिन्स का लेवल कम होगा तो अल्सरेटिव कोलाइटिस के फ्लेयर अप्स रेदर बढ़ जाते हैं. सो आई एग्री टू द फैक्ट दैट द लीडिंग कॉज ऑफ फ्लेयर अप ऑफ अल्सरेटिव कोलाइटिस इज स्ट्रेस. जैसे किसी को एग्जाम का स्ट्रेस है तो अल्सरेटिव कोलाइटिस का इंसिडेंस इंक्रीज हो जाता है, बट इवन नॉन स्टेरॉइडल एंटी इन्फ्लेमेटरी ड्रग्स आर इंपॉर्टेंट कॉज ऑफ फ्लेयर अप्स और आई वुड से वर्सनिंग ऑफ आईबीडी, जहां पे आप फिर ब्यूटेसोनेट एनीमास को यूज करोगे. ऑप्शन नंबर ए में गलत क्या है? सिर्फ एक क्रोमोसोम का नंबर है. कार्ड 15 जीन जो होता है वो क्रोमोसोम 16 पे होता है. क्रोमोसोम 15 पे तो मार्फन सिंड्रोम पढ़ते हो ना वैसे भी यार. सो आई मीन क्रोमोसोम 16 पे कार्ड 15 जीन होता है. इसको आप एडिशनल ऐड कर सकते हो हमारे पैथोलॉजी के नोट्स में, मेडिसिन के नोट्स में, बट मेनली आई मीन द ऑब्जेक्टिव वाज टू ट्रबल यू अ बिट. सो इफ यू गॉट इट करेक्ट, गुड. इफ यू गॉट इट रॉन्ग, डोंट बी वरीड अबाउट इट. सिंपली आई हैड टू जस्ट पंप यू अप ताकि आप और पढ़ाई करो, बिकॉज लिमिटेड डेज आर लेफ्ट. So the more you will put up your efforts, the more you will say, okay man, I'm gonna do it. Don't worry about कि कितने marks आ रहे हैं, because the usual messages that I'm getting, and that's one another reason why I'm conducting this session is कि सर जब क्वेश्चन गलत हो जाते हैं तो बहुत ज्यादा डिसअपॉइंटमेंट होता है. आई एग्री टू दैट, लेकिन क्या है कि आपको बार बार प्रैक्टिस करना है. तो कहते हैं ना कि इफ यू शार्पन योर एक्स, आई मीन यहाँ पे आप, आई नो दिस वेरी लेस टाइम फॉर प्रीचिंग and I would like to restrict myself to theory, but the more you sharpen your axe, the better you a woodcutter you would be. I mean, you need to slam hard, you need to cut down a tree. Then it's, I mean, that may not be a very good example. I mean, just in the spur of movement, I said, I mean, we are all eco-friendly people, but I want to say that you need to continuously practice so that you can keep your reflexes going. Okay, answer to 4 is E, and we go to the next one. Accuracy of pulse oximeter is affected by, and you need to select more than one correct option. And yes, ऑप्शन ए says use of vasopressors. तो वेजोप्रेसर है अगर किसी पर्सन में, तो मतलब पर्सन शॉक में है ना, और अगर पर्सन शॉक में होगा तो पल्स ऑक्सीमीटर का जो एक्यूरेसी है वो तो अफेक्टेड हो जाएगा. तो ऑप्शन नंबर ए तो बिल्कुल सही है. आई मीन यस, accuracy is affected by a person in shock, the values would turn out to be relatively lesser. B says concomitant jaundice in a person. तो नहीं, jaundice से तो फर्क नहीं पड़ता है. Hyperbilirubinemia does not cause much damage. Methemoglobinemia will cause a problem. Carboxyhemoglobin will cause a problem, but not jaundice in a patient. C होता है acrylic nails. इनफैक्ट मैंने जब मतलब फर्स्ट टाइम मैंने वर्ड पढ़ा ना एक्राइलिक नेल्स, मुझे नहीं पता था एक्राइलिक नेल्स क्या होते हैं. आर्टिफिशियल नेल्स होते हैं, जैसे आपने देखा होगा कई बार ना, गर्ल्स, राइट, आई मीन दे विल बी पुटिंग अप दीज आर्टिफिशियल नेल्स जस्ट टू मे बी फॉर गोइंग टू अ पार्टी और समथिंग. तो एक्राइलिक नेल्स मतलब आर्टिफिशियल नेल्स अगर किसी ने लगा रखे हैं और किसी को कोविड-19 निमोनिया है, आपने पल्स ऑक्सीमीटर लगाया, तो क्या एक्राइलिक नेल से I mean, would it affect the saturation? The answer is no. Acrylic nails do not affect it. Carbon monoxide poisoning definitely does. So दो ऑप्शन यहाँ पे सही हैं. That would be A and D are correct. So correct answer to this question will be option number 2. And in the PDF for your convenience for pulse oximeter, मैंने यहाँ पे mention कर दिया है कि कहाँ पे low readings आती हैं, कहाँ पे unreliable readings आती हैं. Like falsely elevated carboxyhemoglobin में हमेशा याद रखना false elevated values आती हैं कार्बन मोनोक्साइड पॉइजनिंग में. तभी तो I mean it's ABG that is recommended for carbon monoxide poisoning and not pulse oximetry. And why is pulse oximeter recommended in the right hand, in the middle finger? तो मैंने डिस्कशन दिया है. आई होप यू लिसन टू दैट ऑन माय चैनल इटसेल्फ कि राइट हैंड तो इसलिए कि राइट डोमिनेंट. इफ आई एम माई सेल्फ अ राइट हैंडेड पर्सन, तो राइट हैंड में मसल मास मोर होगा एज कम्पेयर टू लेफ्ट. तो अगर मसल मास मोर होगा तो ब्लड सप्लाई विल बी मोर. एंड वाई मिडल फिंगर? बिकॉज मिडल फिंगर विल बी हैविंग ब्लड सप्लाई द मैक्सिमम फ्रॉम बोथ रेडियल एंड अल्नर आर्टरी. I repeat the fact once again. Why right hand ka middle finger is recommended for pulse oximeter or index finger, or sometimes even the thumb also, but usually they say middle finger, index finger, because they have the maximum supply from the radial artery and the ulnar artery. और राइट इसलिए क्योंकि मसल मास भी ज्यादा होता है। I mean, जो भी डोमिनेंट हेड होता है उसमें द मसल मास विल बी मोर। एंड ये मैं इसलिए भी आपको बताना चाहता हूँ कि पीछे देयर वाज अ सोशल मीडिया पे था ना, वन गाय वाज पुटिंग पल्स ऑक्सीमीटर इन 5 डिफरेंट फिंगर्स एंड सेइंग अलग अलग रीडिंग आ रही है। तो अलग अलग रीडिंग क्यों आ रही है? क्योंकि हर फिंगर की ब्लड सप्लाई अलग अलग होती है ना। रेडियल आर्टरी, अल्नर आर्टरी की ब्लड सप्लाई डिफरेंट है। सो बिकॉज ऑफ द डिफरेंट ब्लड सप्लाई ऑब्वियसली देयर कैन बी डिफरेंसेस इन वैल्यूज आल्सो। तो ये नॉन मेडिकल लोगों को तो मैं नहीं समझा सकता हूँ कि ब्लड सप्लाई क्या होती है, पल्सटाइल फ्लो क्या होता है, नॉन पल्सटाइल फ्लो क्या होता है। बट यू गाइस एज टेक्निकल पीपल कैन डेफिनेटली अंडरस्टैंड दैट वी हैव टू सिलेक्ट अ फिंगर जिसका मैक्स फ्लो होता है, सो दैट इफ देयर इज अ ड्रॉप, that the drop can easily be picked up. Moving to the next question, this talks about a 30-year-old woman who's having complaints of recurrent episodes of epigastric pain and is taking Digene gel, pantoprazole, 1 tablet daily for last 1 week. So आपको पता चल गया कि गैस्ट्राइटिस पे क्वेश्चन है, पेप्टिक अल्सर डिजीज पे क्वेश्चन है। उसने खुद ही लिख दिया, जनरल प्रैक्टिशनर इज सस्पेक्टिंग पेप्टिक अल्सर डिजीज ड्यू टू H. pylori infection. Which of the following test will be least useful? That's the key word of this question. Maximum useful नहीं बोल रहा least useful for diagnosis of this particular case. Yes guys, I think this is one of the easiest questions that I'm asking you today. So can I have the answers? Please comment in the chat box while I give you a description. Option A says upper GI endoscopy. So yeah, I mean upper GI endoscopy will help me identify whether there is a duodenal ulcer or whether there is a gastric ulcer. I mean, after all, there are two things. One, whether ulcer is there or not, and second is the location of the ulcer and the size of the ulcer. Because patient has been taking pantoprazole for almost last 1 week, no improvement. So I want to be sure if there's an ulcer present. Okay, where is it located? Option B says rapid urease test. Now urease test can be done obviously with upper GI endoscopy. Then is urea breath test and stool antigen for H. pylori. तो दो ऑप्शंस पे तो मैं यहाँ पे मार्किंग कर रहा हूँ। अपर जी एंडोस्कोपी तो डेफिनेटली करेंगे क्योंकि अल्सर का लोकेशन चाहिए। यूरिया ब्रेथ टेस्ट यू वेरी वेल नो इज वन ऑफ द वेरी convenient screening tests for identification of the incriminating agent that is H. pylori. क्वेश्चन ने पूछा है लीस्ट यूजफुल, क्योंकि अगर मैक्सिमम यूजफुल यहाँ पे बोलता तो मैं तो बोलता भाई पहले यूरिया ब्लड टेस्ट कर लो और उसके बाद में एंडोस्कोपी कर लो, डायग्नोसिस बन जाएगा। बट इज आस्किंग यू लीस्ट यूजफुल, सो द आंसर हैज टू बी ईदर ऑप्शन नंबर बी वर्सेस डेल्टा। सो यस गाइस, प्लीज कमेंट इन द चैट बॉक्स, गिविंग यू लास्ट फ्यू सेकंड्स ऑफ टुडेज डिस्कशन। आई मीन फॉर दिस पर्टिकुलर क्वेश्चन आप मुझे बताओ कि व्हाट वुड बी the answer to this question, and I'll just use a different marker anyway to get the correct answer. Okay, so had a lot of outputs, right, inputs from you guys. I want to highlight that a couple of you have not got this question correct. Stool antigen test for H. pylori will also be done for this case and can be a non-invasive test. The least reliable case or least reliable test for this person is rapid urease. And I know that there would be a possible query mark on your face, sir ये कैसे? आपने तो बोला था rapid urease test is as good as urea breath test, then why rapid urease? तो देखो rapid urease test जो है जब भी उसको करना होता है तो PPI इसको बंद करना होता है। If somebody is gonna be taking PPIs, then rapid urease test can easily turn out to be false negative and that can result in a misdiagnosis of the patient. In fact, मैं यहाँ पे एक हैरिसन का टेबल दिखाता हूँ। ये टेबल को मैंने ऐप में डाला हुआ है। The only thing is in the app जो क्वेश्चन मैंने दिया वो दिया what is the best test, तो obvious बात है पहला आंसर आपका रहेगा that I will do a UBT or urea breath test that is both for diagnosis as well as for eradication of infection. लेकिन अभी मैंने सिर्फ ये देखना था कि डू यू रीड द एक्सप्लेनेशन ऑफ द क्वेश्चंस एज वेल और नॉट, क्योंकि अगर आपने एक्सप्लेनेशन पढ़ा है यहाँ पे तो इट सेज रैपिड यूरियस टेस्ट कैन बी फॉल्स नेगेटिव विद रीसेंट यूज ऑफ पीपीआईज और एंटीबायोटिक्स और बिस्मथ कंपाउंड्स। हमारा पेशेंट पीपीआई खा ही रहा है। इस पे बहुत सारे लोगों की क्वेरी होगी कि सर ऐसा कैसे? आई मीन व्हाई इज इट कि पीपीआई खाने से क्या बैक्टीरिया यूरियस प्रोड्यूस करना कम कर देगा? तो जी हाँ, डेफिनेटली दिस हैज बीन शोन दैट पीपीआईज का दो एस्पेक्ट्स हैं। एक तो व्हाट इज सरप्राइजिंग बोल रहा हूँ, पीपीआईज का एंटी माइक्रोबियल इफेक्ट भी होता है, उसको छोड़ दो। आई मीन दैट्स नॉट वेरी इंपॉर्टेंट, लेकिन आपको ये याद रखना है कि जब आप पीपीआई देते हो तो पीएच चेंज हो जाएगा ना भाई। यू आर गिविंग अ प्रोटॉन पंप इनहिबिटर, इट विल चेंज द पीएच ऑफ द स्टमक म्यूकोजा। तो बोलता है कि जब यू चेंज द pH of the stomach mucosa, then there can be suppression of the urease production. आप H. pylori का पैथोजेनेसिस फिर से पढ़ना, जो मैंने बताया है इंग्लिश या इंग्लिश वर्जन में से। मैंने बोला है यूरियस इज रिलीज्ड in response to the major trigger is alkali, दैट अल्कली इज के प्रोपोर्शन में यूरियस रिलीज हो रहा होता है। अगर आप पीएच चेंज कर दोगे तो यूरियस का प्रोडक्शन भी कम हो जाता है, तो रैपिड यूरियस टेस्ट माइट एक्चुअली बी फॉल्स नेगेटिव। In case a person is taking PPI, antibiotics obviously because they will kill H. pylori. Similarly, bismuth also has an antimicrobial effect. तो therefore इस क्वेश्चन का आंसर है बॉम्बे। I know थोड़ा सा कई बार डिसअपॉइंटमेंट होता है, बट देन इफ यू गॉट इट राइट आई एम वेरी हैप्पी। इफ यू गॉट इट रॉन्ग तो नहीं होना चाहिए था, दैट्स आई वुड से थोड़ा रीडिंग का इशू है। Okay, guys, so let's do the last one for today. Alcoholic patient दारू पी के चल रहा था, slept on the wet pavement and is brought in the unconscious state by the bystander. तो GCS of the patient is 8 on 15, कोमा की तरफ जा रहा है। There is no posturing at the moment, क्योंकि अगर posturing स्टार्ट हो गई मतलब उसको transtentorial herniation स्टार्ट हो गया। मार्क माय वर्ड्स देयर, जब भी posturing स्टार्ट होती है that means the transtentorial herniation has started. The doctor on duty has rather made a diagnosis of uncal herniation. Uncal herniation would mean mid-brain herniation. Transtentorial herniation means brainstem is sinking down. That is when you get a posturing. The doctors made a diagnosis of uncal herniation based on the CT head. So which of the following features would have prompted the physician to make this diagnosis? तो देखो अंकल हर्निएशन में एक बड़ा करेक्टरिस्टिक सा फीचर मिलता है। I'll just try to hand draw this before you so that you can appreciate option number A relatively better. So please give me few seconds to just make it before you. Let us take this green to be the representation of the skull. ध्यान से देखना, this is the bleed which is occurring in this patient. जैसे जैसे ये bleed will put pressure on the brain, it will also cause this crus cerebri. ये वाला जो हिस्सा होता है, this is what is called as crus cerebri. It will push this crus cerebri against the calvarium. मतलब एक साइड पे राइट में ब्लीडिंग है तो ब्लीड जो है राइट में है, it will push the brain to left. तो because of this shift, crus cerebri will be pressed against the calvarium, और crus cerebri से एक पाथवे जा रहा होता है जिसका नाम होता है corticospinal pathway, जो कि नीचे मेडुला पे जाके क्रॉस ओवर करता है। Now look at the very surprising thing that will happen. अगर let me put up sides there, ये left side है, this is the right side, the bleeding is occurring on the right side, it is pushing the brain towards left, so it will press on the left side का crus cerebri, और जब left side का crus cerebri press होगा तो corticospinal pathway जो मैंने blue color से दिखाया वो भी compress हो जाएगा, और corticospinal pathway के compression की वजह से person को hemiplegia हो जाएगा। लेकिन वो हेमिप्लीजिया किस साइड पे होगा, तो वो कॉन्ट्रालैटरल टू ब्लीडिंग नहीं होगा। आप देख रहे हो द क्रस सेरिब्राई से जो कॉर्टिकोस्पाइनल पाथवे नीचे जा रहा है वो मेडुला के लेवल पे जाके क्रॉसओवर कर जाएगा, तो जो पैरालिसिस है वो सेम साइड पे होगा। आप बोलोगे सर राइट फ्रॉम आवर फर्स्ट ईयर ऑफ मेडिकल कॉलेज वी हैव बीन टॉट दैट व्हेनेवर देयर इज अ इंजरी टू वन साइड ऑफ द ब्रेन द पैरालिसिस ऑलवेज अकर्स ऑन द ऑपोजिट साइड। यू आर सेइंग सेम साइड। Yes guys, what I'm teaching you here is what is called as Kirohan-Voltman sign. Kirohan-Voltman sign is a false localizing sign. Why false localizing sign? क्योंकि hemiplegia same side of bleeding पे मिल रहा है। वो same side of bleeding पे क्यों मिल रहा है? Because of this anatomical infrastructure. The crus cerebri is pushed against the calvarium, so the corticospinal pathway of the patient is gonna be crushed. But corticospinal pathway तो crossover करता है, तो person को ipsilateral hemiplegia मिलेगा। Please remember, in whole of neurology, there will always be contralateral hemiplegia whenever there is a CNS injury. The only time when you read ipsilateral hemiplegia is what is called as Kirohan-Voltman sign. और ये मत सोचना कि सिर्फ इन्हीं सेट के लिए है, ये आपके FMG एग्जाम में पूछा हुआ है सर। Kirohan-Voltman sign is it is ipsilateral hemiplegia, that means जिस साइड पे ब्लीडिंग होता है उसी साइड पे वीकनेस आ रहा है। जबकि नॉर्मली तो भाई ये पढ़ाते हैं ना कि ब्लीडिंग होगा तो पैरालिसिस ऑपोजिट साइड पे होगा, लेकिन Kirohan-Voltman साइन इज अ फीचर ऑफ मिड ब्रेन हर्निएशन, ये अंकल हर्निएशन को बताता है। अब यहाँ पे एक एडिशनल फैक्ट देखते हैं, सो आई जस्ट डू अ इंक चेंज सो दैट आई कैन इनकॉर्पोरेट वन मोर फैक्टर। देखो यहाँ से ऑरेंज कलर में मैंने जो दिखाई है वो ऑक्यूलोमोटर नर्व है, तो ब्लीडिंग जब होगी तो bleed will also press on the oculomotor nerve, and when it will press on the oculomotor nerve, so let's see what will be the impact of the pressure on the oculomotor nerve. You are gonna be shining a torch in both eyes of the patient. The doctor is shining a torch. Doctor is not aware wherever is the bleed present, he's just shining a torch. So whichever side the pressure is there, that side the pupil will react very poorly. So I have shown a mid dilated pupil. You can notice that on one side the pupil is showing good response, but other side, because there's a direct pressure by the bleed, the pupil is showing a poor response. So there is unequal pupils. That unequal pupil is what is called as anisocoria. So yes, even ipsilateral anisocoria can be present in the patient. Option number A and B definitely make sense for mid-brain herniation. Mid-brain herniation को uncal herniation, uncus, UNCAS, not uncle वाला, UNCUS, uncal herniation बोलते हैं, और इसमें आपको ipsilateral hemiplegia और ipsilateral anisocoria मिल सकता है. Irregular respirations, तो respiratory center कहाँ होता है? मेडुला में होता है. Irregular respirations is a feature. In fact, I'll just use a finer print so that you can remember. जब chain stokes breathing आ जाती है, like a head injury patient is having chain stokes breathing, it's not showing I think, so I'll just use a different ink. In case a person is having chain stokes breathing, that implies that the person is having transtentorial brain up. पहले तो mid brain compressor होता है, brain नीचे की तरफ जा रहा है, उसको बोलते हैं transtentorial herniation. Chain stokes breathing is a terminal event that occurs. Irregular respiration occurs. That's a periodic breathing. I've explained that in the main app, so I don't need to go into that. Irregular respiration is a feature of transtentorial herniation. और finally जब patient brain dead होने वाला होता है, जब anterior cerebral artery, middle cerebral artery, जो main arteries है brain की, posterior cerebral arteries की सबकी supply affected हो जाती है, तो terminal event में आपको मिलता है as a last event white cerebellum sign. ऑप्शन नंबर सी और डी जो है वो बहुत लेट स्टेजेस में मिलते हैं, एंड बिफोर द पर्सन विल बिकम ब्रेन डेड व्हाइट सेरिबेलम साइन मिलता है, जो कि खुद ही आप देख रहे हो ना, अलग से सेरिबेलम का जो एनाटॉमिकल पोजीशन है, वहां पे सेरिबेलम विल अपीयर मोर व्हाइट देन व्हाट इट नॉर्मली शुड बी. एंड यहाँ पे पूरा ग्रे मैटर व्हाइट मैटर का जो डिफरेंशिएशन होता है, वो डिफरेंशिएशन का लॉस हो गया. इनफैक्ट आई शुड पुट अ माइनस साइन हियर. द नॉर्मल ग्रे मैटर व्हाइट मैटर इंटरफेस इज स्ट्रांगली अफेक्टेड, सो यू आर हैविंग a white cerebellum sign. That's a terminal event of head injury, whereas our patient has come relatively early. The correct answer for this particular question is option number A. That is A and B are the correct statements. And well, these are a couple of issues which I want you to remember for today. You can mail me at marvamedicine@gmail.com, and I'll be glad to send you the PDF of this document, which will include the genetics component. Or you can simply join the Top Educator Telegram group. The link of that is given in the starting of this PDF. In fact, the first slide as well. You can very well see this, and you can join via this, or I mean, if you can mail me, that's great. I'll be glad to assist you. So guys, thank you so much for joining with me here and attending this discussion. Just keep on practicing on a daily basis, and I'm very sure all of you will come out with flying colors. Thank you so much for your patience.